GvHD Hub podcasts, brought to you by Scientific Education Support.
Hello and welcome to the GvHD Hub podcast. Today we'll be hearing from Daniel Weisdorf from the University of Minnesota in Minneapolis, US.
I'm Daniel Weisdorf at the University of Minnesota, and I wanted to comment on how we stratify risk for patients with acute graft versus host disease. The original staging and grading system was published many years ago on a limited number of patients, all of whom received bone marrow transplants and all at that point from matched sibling myeloablative grafts. A lot has changed in the field, even though the symptoms of acute GvHD have not. There are a variety of schemas that have been presented over time, one from the CIBMTR, one from other groups, and we published a number of years ago with my colleague Margaret MacMillan leading the effort, a Minnesota risk score which really focuses on bedside information, the extent of stage involvement of skin, liver, gut at the onset of the disease. And we demonstrated that Minnesota limited versus extensive or mild versus severe can be used to well predict non-relapse mortality and response to therapy. The staging is using the original staging criteria with the addition of the consideration of upper GI graft versus host disease, and people with limited or less severe Minnesota grade acute graft versus host disease either have single organ involvement or involvement of limited skin and just the upper GI tract, whereas people with multi-organ involvement have more advanced grade. And that's been associated, as I said, with both response to therapy and non-relapse mortality. It's been used in a number of clinical trials that have stratified patients according to this and been able to sort out who's more and less likely to respond, and therefore has balanced the attribution of risk for patients involved in these clinical trials. There may be addition of information that could come with incorporating biomarkers into the Minnesota grading system, but that of course needs further explication to be able to sort that out. There's a variety of different biomarkers that have been proposed for use. None have necessarily replaced the clinical grading and staging that can be done right at the onset of disease. And we think that the advantage of using the Minnesota grading and staging system is that it can be done with the bedside presentation of symptomatology that everyone can score, doesn't involve waiting for biomarker information, and can be used to stratify patients both for therapy choices and for clinical trials. The value overall is to make sure we don't overtreat patients with highly responsive disease who might be spared the side effects and toxicity of excess treatment, and to identify patients less likely to respond who can better benefit by either more intensified treatment or perhaps be enrolled in clinical trials to manage their disease. And thanks.
Thank you for listening to the GvHD Hub podcast. We would also like to thank our supporters, Insight, Novartis, and Syndax.
GvHD Hub podcasts, brought to you by Scientific Education Support.